You know what I've never figured out is how to utilize, like, if I'm looking at a QR code right now and I'm on my phone, I can't like tap it or take a screenshot to use the QR code. So then I have to click on the link in the email or like type in the chat to record my attendance. You would think that by now they would have made it where on the Zoom call or whatever, you can actually tap the QR code from within, you know?
Yeah, trying to think, you might be able to, harder to explain, easier to show you. You might be able to move that window aside and then open your camera, but still have the meeting, because you're on the meeting on your phone too.
Right.
Yeah.
Yeah, it's something that's always confused me. And then I
Mhm.
will probably accidentally like end the call if I try
Oh,
to like move.
all right, you got a pretty good group so far, about 29 or so, excluding us.
Dr. Register, do you want me to log your attendance for you?
April, that would be amazing. Thank you.
I'll take care of that.
Look at
Thanks.
that. That's so nice. Can you bring her a cup of coffee too? She would probably need that.
I'm not quite sure even where she's physically located right now, but
I am in my office
ah,
and I am looking at a cup of coffee right now, but thank you. So yeah, we've got 35 participants and it's right at 8:30. So thank you everyone for being on time. We all appreciate that. But yeah, I think we've definitely got enough. Are you okay with it if I go on and get started?
Yes, please.
All right. Good morning, everybody. I hope you're all doing well. So, if everybody can either with the QR code or the link in the email or just let Gabby know, that you're here. Um, if everyone's had a minute to look over the last meeting's minutes in April, if anybody wants to make a motion to approve those meeting minutes.
I move we approve those minutes.
Thanks, Damien. And Sienna seconded. Thanks, guys. Okay, moving forward. Liz, do you mind giving us some GTC updates?
I would be happy to. Just a couple updates. We're in prep for our upcoming meeting, as you are all well aware. Our summer meeting combined with GQuip is next month on the 21st and 22nd at the Macon Marriott Center. And besides that meeting, we have been required to submit our FY 2027 preliminary budget already. So we start working very early on fiscal year budget for the next year. Typically, what we do is just use the current budget kind of as a template, because as you guys know, things rapidly change, and we'll see what happens towards the beginning of the legislative session when the governor's budget report comes out, and we'll get more information about what if the additional 4 million that we've been getting will stay in there or not. So that's that. We just had to turn in edits to our strategic plans. Dr. Register and I had a conversation yesterday potentially about doing somewhat of a goal setting for this group based on, now that we've got so much data coming in from different surveys, including the survey that we did a couple years ago with the rural resource needs assessments, reaching out to all rural centers in the state, not just level 3 and level 4 centers. So pretty robust set of data we have there. So now we just need to make sure we're setting some goals around that. Thanks to the centers who are participating in the Qcentrics inter-rater reliability program. I think of all the centers participating, we have one that's fully through all the, I believe that's Morgan, that's jumped all the hurdles of IT. And if you're having any issues or struggling or you need help, please, don't hesitate to reach out. The Qcentrics team copies me on all of their communications. So I'm aware of some of the struggles that some of you are experiencing, but if there's anything you want to talk about, just, please feel free. You can always reach out to me. And then finally, if you're wondering where your FY26 contract is, you didn't miss an email. We are in the throes of a hard edit to the contract language. And by hard edit, I mean the state has changed what they call their contract shell language, or what we previously used to refer to as the boilerplate. And it's a lot of just, very tedious language to go through. It is quite long. I apologize to say that, but we're working with the Attorney General's office to remove some of the things that just don't apply to what our purposes are, because you guys aren't making widgets. We're not contracting with you to make widgets. It's a different beast altogether. So thankfully, they understand that. And but the part of the contract that has to do with all the work you do and performance-based payment, and for the level 1s and 2s uncompensated care, that language was very old and outdated. And so all of that has been revised, and we're close to getting the level 1 contract done. We're doing it by level. So most of that language will carry over to the 2, 3, and 4. So I don't know if Katie's on the call, and I can't remember what we set our target date to be August 1st. So again, I apologize that that the contracts are so late, but we want to be intentional and make sure that since we took the time to do this hard edit, that it's right. And then they will be released to you soon.
And I'm here, Liz.
Oh, great, Katie. Was it August 1st that we had for the level 1 contract?
Yes, that
Okay.
is the target. Yep.
Thank you. So unless there's any questions, Dr. Register, that's all I had for the group this morning.
I don't think so. Thanks, Liz. And if anyone does have any questions and you want to ask it outside of the group, feel free to either email me or Gabby or Liz. We're easy to get in touch with. Okay, so moving on to old business. Is Courtney on the call? If not, I can give a March pause update.
He is traveling, and he wasn't sure if he was going to be able to get on. And I spoke with him this morning. Dr. Register, if you and I want to tag team the update, you start and I'll fill in if any holes, if there are any.
Okay. Thanks, Damien. So mostly the biggest update is collaborating with Dr. Mabes in Augusta, and utilizing their kind of academic powerhouse resources and things that the program that they, the simulation program that they presented at the, what was it, April, when we were, or no, February, when were we in Callaway? Anyways, when we were at Callaway, they presented what they had been doing. And after that, we were like, wow, this is really similar to March Pause. We should work together. And so Courtney Twilliger and Dr. Mabes have gotten together, and we're figuring out kind of how to merge the efforts and be able to utilize the March Pause grant towards that. So it's not two separate efforts that are very similar in the state, working separately. So that's kind of the biggest update, is being able to collaborate with AU and the efforts they've already got going. I think it's going to really help with the manpower issue we were having, why March Pause really wasn't moving forward. We just didn't have enough people to do it. And so now we do. And Dr. Mabes is incredible. If you ever get the chance to talk to her, she's so encouraging. And I'm just really excited to see March Pause take off with them. Damien, do you have anything else?
No, just some logistics, all of that, the grant funds have been, moved around, and they have their funding to do that. So that's great. The other component of that is that we've got a company that's going to be providing some videography for that to be able to get some of it on video, but also as part of that, they're going to do a series on the different levels so that we can use that to educate, I think, both Liz, I think that's going to be used to educate both the public, but also maybe legislators about the roles of the different trauma centers and have some firsthand, um, just people talking about how that trauma center impacts their community.
Yeah, exactly, Damien. That's a great characterization of it, because I think we need a lot of public education out there, and we've just had dialogue about trying to get myself and Dr. Ashley in the same place next month to try to launch the kind of informational videos. So not necessarily like, PowerPoint and teaching someone, but just kind of talking about the importance of organized trauma system. And I think that will be we'll be able to use that really broadly to do education. So it'll be great.
Yeah, I'm excited. I look forward to seeing, what the group at Augusta, Wellstar, MCG, whatever they're called, but to see what they can produce with this fellow, and I think it's going to be a really great, has the potential to be really great for us.
I will say that Dr. Mabes, she is, Alicia, the two of you together, it's just very exciting to see how this is going to sprout. But she copies me on everything just for situational awareness. Damien, not sure if she's copying you too, but she is aggressively out there setting up times, and there's all kinds of logistics with these sort of things, but she is working so hard to make sure that they've got a good kickoff to this program. So I'm so excited to see it move forward, and thanks for sticking with it and not getting frustrated, because ultimately it will be a great thing for the rural trauma community. So excited.
Well, we stuck with it. I didn't say I wasn't frustrated, but we're sticking with it. I just want to get it over the finish line and get some things out there. And the nice thing about everybody on this call is they've really taken effort to be part of the trauma system. And there's a bunch of hospitals. I've got the map pulled up now around us that are not part of it. And I think for valid reasons, just the expense and time commitment. But if there's a way that we can not only strengthen our level 3 and 4s through this program, but also through some outreach to those others, we can improve trauma care. And really, we also may convince some others to become part of the program.
Yeah, those are all great points, and they really dovetail nicely into when we're gonna, I guess we can go on and move forward to the Pennsylvania trauma system consult visits. So is that okay if I move on to that? Because it really kind of all ties in together. Pennsylvania Trauma System Foundation came back down again. They came a couple years ago, and so some of they came to 2 of the 5 original hospitals, if I've got that number correct, I think. So and the reason why they weren't able to hit all of the 5 original ones is because just different reasons. One is no longer a trauma center, and then just for other different reasons, the timing of their visit didn't work out, but it's okay. We got some really good feedback. And I think it really fits also into the results that we got from the survey we just sent out to this group. So we'll start out by just going through their findings. So the first point is that they found a really strong commitment from these hospitals to be trauma centers. They're enthusiastic, they're dedicated, they're well equipped. Their commitment to the community through community outreach and injury prevention efforts are strong. They have strong commitment to nursing education. And a lot of the nurses have taken or are taking the TNCC course. So there's definitely a strong commitment. There's a strong desire to provide excellent trauma care. And that's what's most important. You've got to have that. If you don't care, you're not going to do a good job at anything. So Then going on to point two is the clinical care. So there's frequent under triage, and I see that. And so then it's kind of like, okay, well, why? You know, why are we consistently under triaging some of the more critical patients? And so then it's also a inconsistency with utilizing ATLS protocols and algorithms. Um, they do say that the hospitals and the resuscitation areas are well equipped. So that goes back to the point number one, that they've got the equipment, they've got the effort, and then something that needs improvement is utilizing the electronic medical record for consistent trauma documentation. And I mean, I see this too. So, point number three, performance improvement. So PI, everybody's favorite topic. Um, uh, so it kind of like what they're saying is let's use the technology to our benefit. There's a lot of basically it's let's work smarter, not harder, and use the databases to our benefit. But we've got to learn how to use those databases to work for us. So that's kind of the gist of the PI point that we can improve on, is let's use the data we have to then do PI, and how can you do it without a lot of manpower and time and tedious efforts? That is how it's being done now. I think there was a second one there, second page. Maybe not. Okay. So those were the summaries, and we don't have to
Yeah,
go through
actually,
like every tiny little thing, but yeah, those were the main things.
there's actually like 3 or 4, yeah, there's 3 pages.
Okay.
It tease out a little bit. They talk about under triage, and then they talk about transfers, and specifically, and I'm sure there's a lot of frustration in this group with getting feedback from your tertiary centers when you send
Mhm.
your patients off. And then interestingly, they said about performance improvement that despite folks attending educational courses, that there still wasn't a great use of performance improvement plans. So the question I would ask you, Dr. Register, and for the group, is that maybe the group can ponder this and think about, are there other educational opportunities we need to look at? And if so, the group could bring them, you could bring them forward on behalf of the committee to the commission for consideration of funding. And a lot of those courses don't cost a lot of money and can be done virtually. So just some.
Right. No, I think those are the good points. I mean, I've taken the rural topic even a couple times, and I still get confused during it. No, I mean, I'll be the first to admit that. So, it is one, and everybody says that when you take topic, like you get something new out of it every time you redo it. But it's also kind of like, well, if you're retaking the same course over and over, and so maybe there is another way that's more effective. I think, and this is just me, and I definitely want to form some focused work groups after, like at the end of this call. So we don't have to solve all the problems in this call, but I do just want to throw out there, let's make a work group focusing on that. How can we, improve our PI processes as a whole? And I really think the mentoring group is going to be helpful in that, hey, guide me, coach me how to do better PI. And so we can tag team people that are doing a really good job at it with some that need help. So, but yeah, so transfers, well, let me just, so under triage, I think that it kind of ties back to the, we've all been talking about we need standardization of care. And that's also across, so one, that's across individual providers within the same department, who's working today. But then also it's standardization across trauma centers. And that was one of the big things we that we'll talk about in a minute when we go over the survey results. But again, what PTSF found and what we said we know we need help with were the same things, which is good, you know? And so one of those is standardization. And so I think that if we kind of can come up with a set criteria, it doesn't have to be the same for every hospital, but hey, in general, this is what we all agree on should be a tier 1 activation, a tier 2, a tier 3, or however many you're going to have at your hospital. And I think that will help standardize across not just individual providers in the same ER, but all, ERs, that are trauma centers on. And that way we can cut down on these under triage rates, because those are, I'd say riskier definitely than over triages. So, so I think we need to start a work group on that too. So under triages and then PI performance, and then also, transfers. So, again, it kind of comes down again to, we need more EMS, and we need to figure out a more kind of organized way of how do we get these patients transferred out. Liz, you have anything else to add to that?
No, I think you covered it really well, but I love the idea of having work groups, because I think that will help us make best use of our time, and it's just hard to kind of solve problems on these calls, as you alluded to. So look forward to that.
So if anybody is interested in any of these topics, I don't expect you to, I don't want one person on all three, that's too much. But if there's one that you just are really passionate about, please email me or Gabby, and we can help send out some more focused emails and get those going before the August meeting. Okay, so I guess we can move forward unless anybody has any questions or comments about the PTSF visit. So the trauma connect, Rachel, or Christy, or y'all on I think Rachel said she was on the call earlier.
Yes, Dr. Register, I'm here. Can you hear me okay?
Awesome. I sure can. Thank you.
Excellent, no problem, thanks. So brief synopsis, the Trauma Connections group met the last couple of months. Variety of topics were discussed, some of which were coinciding with the themes that we just discussed with the PTSF aggregate findings and recommendations. And so it was things like PI and the EMS transports. One other piece that we were actually discussing earlier this week was the utilization of EFASTs and the validation processes that exist surrounding that process to ensure, positive quality improvement efforts and things like that. So if anyone is very robust in that process or has a good practice in place as far as ensuring consistency with those EFASTs and having some sort of a quality system in place in order to make sure that the reads are being done correctly, or that overreads are being reviewed, things like that. If anyone has anything like that, we would love to hear more about it. Just to build up our individual programs. I know a lot of people voice that concern and that desire to have that in place. We discussed, let's see, there was some discussion related to the new CMS measures related to geriatrics that was posed to the group. And so we had some discussion about how those geriatric measures don't necessarily apply to critical access hospitals because they're not required to follow those CMS measures, but that non-critical access hospitals should be discussing with their quality directors that those new measures that have been put in place to see if there's anything that they need to focus in on. We talked about, of course, the transfer delays and things like that. I know at our RTAC meeting earlier this week, we actually had a presentation. This was the Region 4 RTAC meeting. We had a or Regional EMS Advisory Council meeting, excuse me. But we had a presentation from a company called RightSight, and it's a company that has been put into place basically to alleviate the burden of non-emergent calls from 911. So ultimately, the short version of this, and I don't know too much about it, but the short version is that if EMS get a 911 call for a non-emergent call, it basically they can refer it over to this other company, and it goes through a screening process with an ER physician, a care team that determines whether or not it's emergent or not. If it's not, then they can take it and they can respond to the call as opposed to the EMS agency responding to it. So the idea is that it again offsets that non-critical burden off of our 911 EMS partners to free them up for the emergent calls. So I'm intrigued on this, and I have a meeting next week to talk with them more about getting this set up in Troup County. So we may have more information coming out of this. I don't know if any of the other facilities on the line are actually using this company or not, but it's Right Site. Is anyone familiar with that? All right, so more to come on that. I'm assuming no one's really familiar. So if I find some good information out of this, I'll bring it back to this group next time. Some of the centers were discussing their use of contracted transport services in order to alleviate or help out with the burden of the extended transfer times. So more to come on that. I know specifically we've got a contract in place with an EMS agency that's supposed to, again, help us with that, but it doesn't go into place until later on this month. So hopefully more to come. Um, we had some offline discussions related to report writer. So some people were seeking out more education related to report writer and how to utilize those reports to their benefit, again, to beef up the PI and reports that they can utilize for designation visits. And this was coming out of their PTSF visits, so more related to that. And then we had some educational opportunities that were presented to the group. So we've got Dr. Alexa Smith is coming to Piedmont Henry on the 23rd of this month. She's given a lecture on pediatric stabilization. They've opened up the invite. So the virtual invite, excuse me, not the in-person invite, but the virtual invite is open to anyone who's interested. So if you're interested in that, reach out to Jay Connolly over at Piedmont Henry. He can get you the invite. And then we had a couple of centers within Wellstar that have Dr. Mabes actually scheduled to come out to their facility. So we've got some of those classes on the dates. I believe Spalding has a date over there around October 30th and Wellstar Douglas August 29th. So those dates were shared with the group for anyone interested in being a fly on the wall. And then Piedmont Henry also extended an opportunity for a mini burn class. It's like a mini ABLS course that they're doing in Fayette County on August the 8th in conjunction with Grady. So those things were all shared as well. So lots of discussion, lots of questions, and lots of education being shared in that group. So this is great. And I do support what you said earlier in the sense that I think that mentor group, if we have some specific focus points that maybe come out of the PI work group that gets created, we can definitely harness those and we can spend some more time building those in order to build up our PI practices and stuff across the level 3s and level 4s. So good things. Any questions or anything for me?
No, that was a really great summary, Rachel.
Yeah,
Thank
thank you.
you.
I know it was a lot. Sorry.
No, you're good. Yeah, no, and I'm glad you brought up about the EMS reports, because that was something I don't think I mentioned when we were going over the PTSF visits. There was something they said that basically, again, it goes back to efficiency. Let technology work for you and not be, you know, redoing multiple steps that all do the same thing. That they're talking about EMS reports communicating into the patient's, maybe not the patient's record, but you know, being able to easily get those without having to individually contact that EMS unit. Yeah, I think that would be good if we could kind of better organize that. Okay. So, moving down to new business, I'd like to introduce our GTC research interns, Megan and Allie. I've had the pleasure of getting to know them and talking to them over the last few weeks. Going through the survey we sent out for the kind of realign or not realigning, but identifying our new priorities. We've really accomplished so much over the last 5 years, and now we need new goals and objectives to move forward. So that was the purpose of this level 3-4 survey that y'all submitted about a month or so ago. So they're going to give us the results of that survey.
Hi everyone. I'm Allie Lights, and me and Megan will be presenting the survey results. So we're both the MPH interns at Georgia Trauma Commission, and we'll be sharing the results of the level 3 and level 4 trauma center survey with priority recommendations based on what we found. So the survey's purpose was to conduct and capture the current challenges, gaps, and priorities by the level 3 and 4 trauma centers across Georgia. And our goal is to identify the future direction and how the commission can best support these centers. So for the respondents, we had 36 participants, including trauma program managers, medical directors, and senior executives. And as many of you know, that these centers are in rural areas. So this plays a role in the stabilization and transfer due to limited on-site resources. This data gives a fresh look on what we may need looking forward. So a quick respondent overview, 44% of the respondents were trauma program managers, 25% were senior executives, 19% were medical directors, and 11% were other. And 53% were level 4 trauma centers and 47% were level 3 trauma centers. And we scored the top ranked priorities. So standardizing trauma care practices with a 3.89 average score and 29% ranking as their top choice. And improving rural patient transfers had 43% of respondents selecting the top priority. And together, these two were ranked the top priorities by over 70% of the respondents. And when asked how effective current trauma care guidelines were ensuring standardized care at the facility, only 34% said that they were very or extremely effective, but the majority found that they were somewhat effective. So this highlights the opportunity for improvement. And then when asked for the areas in need of standardization, a majority of people said the documentation and reporting, with the second follow-up of initial assessment and resuscitation, and then nursing specific protocols. Those were the top 3 areas in need for standardization. And then in terms of training needs and education, a majority of people said that the use of trauma scoring systems were the top training need in education. And then pediatric trauma was a close follow-up. And then the second follow-up was the trauma documentation. So we also explored the preferred training formats and rural support tools. A majority of people preferred peer learning for preferred trauma education and stimulation. And for rural trauma transfer tools, a majority of people said trauma teleconsults, real-time EMS tracking, and transfer hubs. And then for protocol development support, when asked about the protocol development support, the answer was a clear yes. Facilities are looking for help for TBI anticoagulation, trauma activations, pre-hospital blood use, ED compliance, and rural-specific destination criteria. And this confirms that there is a protocol support is one of the most actionable areas for immediate impact.
Hello, everyone. So moving on into the most challenging patient types. So here we asked respondents to select the trauma patient populations that they found the most challenging to manage. So overall, pediatric trauma was the clear outlier here. It was cited by 72% of the respondents. This was followed by OB trauma at 52%, multi-system trauma at 41%, and both geriatric trauma and burns were each cited by roughly a quarter of the respondents. This slide highlights the top resource and staffing challenges that are currently affecting trauma care capacity. So the biggest barrier here, which was cited by 69%, was EMS and air transport availability. Specialty staff availability followed at 59%, and reimbursement concerns were noted by 45% of participants. What's significant in this slide is that most of these barriers are largely systemic rather than clinical barriers. We also saw training budgets were a concern at 38%, showing that the workforce preparedness wasn't just about willingness, it was also about the funding challenges. Meanwhile, infrastructure like trauma bays and equipment shortages were far less frequently cited. In this slide, respondents were asked to rank 6 financial investment areas. Education and training came out on top with the highest average score at 4.59. But transport partnerships also stood out with the highest percentage of respondents ranking at number 1. Other areas like coordination staff, IT, telehealth tools received more moderate support, while staff recruitment and equipment were consistently ranked lower among the respondents. Here we asked respondents to identify the biggest obstacles in transferring trauma patients. EMS and air availability was again a top issue at 79%, followed by receiving facility capacity at 59%, delayed transfer decisions and weather or geographic barriers tied at 31%, and communication issues were noted by 21%. Notably, stabilization was selected by 0% of the participants. Here we wanted to gauge interest in trauma-related teleconsultation services, and the response for this was overwhelmingly positive across the survey. About 73% of participants believed that teleconsultation would reduce unnecessary transfers. 28% of these said it would reduce it significantly, and 45% said somewhat. In terms of the implementation, 86% said their facility would be open to using this service, though many added concerns. So in the written feedback section of the survey, some concerns noted were around liability, documentation responsibilities, or the burden of credentialing external physicians. So this slide organizes the key themes that emerged around the clinical operations and workforce dynamics in the survey. So the first theme and kind of the overall theme of the survey was that standardization remained a top priority. So the survey responses showed that 62% wanted help with trauma protocol development, 66% highlighted documentation as the top workflow needing improvement, and this also aligned with standardization being the most frequently ranked priority overall. The second theme was targeted education. Instead of general trauma refreshers, respondents wanted specific and actionable training. So for example, trauma scale use, pediatric trauma care, and better documentation practices. The education preferences lean towards simulation and peer case reviews, and some participants did call for hybrid learning options. The final theme was persistent workforce and compliance barriers. Many teams noted that they struggled to enforce protocols. For example, several participants noted that their trauma initiatives were stalling due to lack of engagement from contracted ED physicians. This slide captures transfer, telehealth, and resource themes. So firstly, transfer delays were typically not clinical. They were noted to be operational. So for example, this is EMS shortages, bed availability, and unclear decision-making processes that were truly driving the delays. Secondly, there is a high interest in using teleconsultation and the related tools. Nearly 3/4 of respondents believe that this could reduce unnecessary transfers. Third, there was also a call for rural-specific support. This includes knowing which hospitals are open to receiving which types of trauma cases and real-time EMS tracking. Lastly, there was a theme that funding priorities selected in the survey reflected the known gaps. So these top investment areas listed were education and training, trauma coordination staff, and equipment and supplies. So to wrap up, there was 4 key takeaways from the survey. First off was that standardization and rural transfer improvements were the top priorities across all roles and levels. Secondly, education needs are very focused and actionable, especially for pediatric care, trauma scoring systems, and documentation workflows. Thirdly, transfer delays were largely driven by operational constraints such as EMS shortages and facility capacity, not clinical capabilities. And lastly, there's a strong openness to telehealth as a solution, but it's going to require thorough implementation around documentation, credentialing, and care continuity to address all of the concerns. Thank you.
All right, thank you so much. Again, it was really, really a pleasure to get to meet y'all and work with y'all. Y'all did a phenomenal job putting this presentation together and really sifting through the raw data and bringing out the main points. So I think for the sake of time, the best thing moving forward would be to just form these work groups. And then, like I said, y'all email me or Gabby and we can kind of organize these over the next weeks. So just writing notes as we're going through these, I would say the work groups would be standardization and trauma protocols and documentation. 2 would be trauma telehealth. 3 would be PI improvement. And 4, if we want to, I know we've been working on it with the ditch to door project, but transfer improvement. So anybody have feedback or thoughts or comments on at least just what work groups we should form?
I have the chat open too, Dr. Register. So if anybody, you don't want to speak up, but you're willing to type it in, I'm monitoring that for us.
Hey, good morning, Dr. Register and everyone. This is Brooke at Emmanuel. I would definitely love to join the PI program group. That was one thing that I was going to speak to when we were talking about the PTSF visit. That was one thing they kind of gave us for an opportunity for improvement, was just kind of developing a hardier PI plan and utilizing the PI process to capture those under triages like you mentioned. Matt Mallory was the one that visited with us, and he gave us some good resources and things like that. And just us he talked about taking the rural topic course, which, we base a lot of our things on. Gail and I have already taken those courses, but recommended, getting our TMDs to take it with us, and maybe all of us taking it together at the same time so we can collaborate better together to form a more formal PI plan.
Awesome, Brooke. Yeah, that was really good feedback. And we all, those of us everybody's been through, either designation or ACS consult or verification visit. And PI is always, it's the most important part, or one of the big parts, and it's also probably the easiest stumbling block. So I think that that this is the biggest opportunity for an impact, I guess is what I'm trying to say. So I'm excited that so many people in the chat are also saying PI. So thank y'all for your participation.
Another recommendation I was going to share with the group that he listed on our OFIs, he could incorporate the reevaluation and loop closure determination in the PI process and enhance documentation in the registry PI tab. He said he thinks that us, and along with some other places, are probably underutilizing that tool, and it's just something good that can kind of help streamline things and just make it easier. He said, there's no reason to make it harder, that we need to utilize the resources that we have, and it'll make it a lot easier.
All right. That is everything I had that I wanted to go over for the meeting, everything on the agenda. Liz or anybody, y'all have anything else?
Dr. Register, I had a couple things. One is I just popped something in the chat in case you can't see the chat, but I think on the standardization piece, it would be nice to get some physician leaders, TMDs, specifically from the level 4, some ED folks, because at the level 4 center level, the physician leadership's going to be ED, but on the standardization piece, specifically to like ATLS based protocols and stuff, it's, as you and I talked about yesterday, it's, It's hard to get ATLS all over the state. I don't know if there's something else we can do, but we need some physician presence on that piece. So we promise we won't make it too hard and convoluted and too many meetings, but just trying to get together and throw out some ideas. And then the other thing, and just again, just email us directly, or email Gabby. She's sometimes the easiest one to centralize communication through. On the education piece for particularly for the lower level centers, but for threes as well. GTC back in February approved, and we purchased the STN orientation modules. And so you have carte blanche access to that entire orientation module. You can pick and choose what you use from it. It's totally customizable. So you can put facility specific information for your institution in there. It's just that you have to sign a thing that says, you don't take it on the road. It's really just for internal trauma center use only. So it's not available to other other centers outside of our trauma network at this time. So if you want that, and if you don't have it and you want it, you just have to email Gabby, and she has the attestation for you to sign, and then we'll send along the modules to you. But it's just an amazing compilation. It's no need to invent the wheel if you don't have a clinical orientation for your trauma nurses. And for the threes who are going through ACS verification or your consultative visits, this will meet your requirements for getting trauma specific education for your nurses in the trauma bay. I would argue it's also useful for nurses on the in the ICU. It might be a little overkill for nurses taking care of trauma patients on the floor, but again, you can take out the modules that don't apply to them. So,
Hey, Liz, this
Yeah.
is Jan from Carsville. Are you saying using it maybe instead of like TCAR? That's one thing that we've utilized, but is it similar to that, or is it something we can instead of that?
TCAR is a little, I'm really glad you asked that question. Thank you. It's as if I teed you up. TCAR is more for the post resuscitation. I find that that's very physiology based. It's really, to me, it feels more like an ICU type orientation, or, if you want to use it as that. And the ACS actually recommends TCAR. The orientation modules, I would say, are going to be more for your nurses in the bay. It goes through everything from injury prevention all the way on through to, it's a systems based thing. So, head trauma, chest trauma, musculoskeletal, abdominal. And then, it even covers some things about your trauma program and what you guys are looking for when you look at cases. So that's really helpful too. But yeah, I would say it's more for your nurses in the bay. And I wouldn't say it replaces anything. It's more for your clinical, you're still going to want, like if you're using TNCC or ATCN or something like that, you're still going to want those things, but this could be your institutional specific orientation.
No, that's perfect clarity. Thank you so much.
Yeah, and it's got notes to the slides, and I even believe there might be some testing that you could use after the modules. It's really nice. It's really nice. And we purchased it for the state for all the trauma centers, so it's free to use. So please take advantage of it.
That's awesome. Thank you so much for sharing that.
You're welcome.
All right. Does anybody have anything else?
I just have a real brief thing that I just want to bring up. Maybe not for a whole lot of discussion now, but just something that I will be advocating for significantly in the future. I appreciate the survey and I appreciate all the people's work on the trauma system, including my team. But we have got to focus on improving the readiness costs from the trauma commission to the level 4s in particular, but maybe also the level 3s. Otherwise, it's not going to be sustainable for Emmanuel to continue to be a trauma center. So that's going to be hot on my to-do list over the next 12 months because I love and believe in what we're doing on the trauma center, but there's a cost I know, when we did that survey, I guess it's probably been about 4 years ago. I felt like it undervaluated it then or undervalued it then. And even now, our costs are just so much greater than they used to be. So it's something that we're gonna have to address.
Hey, Damien, I'm glad you brought that up because it's already on our strategic plan to do another level 3, level 4 readiness cost survey. And I know that's like a double-edged sword because it's so much work, but as you guys know, we base all the funding formulas, and thankfully now you are funded much better than you used to be. And the level 3, everybody across the board is funded at the same cents on the dollar, with the exception of 4s. Everybody is at about, Katie would know the exact, but I think we're hitting about 7 or 8 cents on the dollar.
That's correct.
And then 4s are funded at 50 cents on the dollar, so half what your readiness cost. But that's because, as Damien alluded to, we didn't get really great data when we did that. Now, granted, it was around COVID time, and people had other things on their mind. We used a pre-COVID data year, but I think overall we couldn't capture the same level of medical provider, which is primarily ED. We couldn't capture those costs, I think, accurately. So I think we're heavy on another level 1, level 2 survey. And then I think we have, I think it's not next year, but it might be the following year that we have teed up for another level 3, level 4 survey. So it's a good time to lay the groundwork for that, Damien. Thank you.
Yeah, and we have a neighbor that recently decided to back away from that for expense reasons. And I just think that, like, especially when you look at the map, we probably need to keep the ones that we have and maybe attract some more. And you're not going to do it to be rich, but you also don't want to do it. I suspect that the next few years, and especially the next 12 months, are going to be really, really challenging for the rurals. Somebody on the phone might disagree with me, but I think that as things get more challenging for them financially, they're going to hold everything up to the light a little more carefully. And we don't want to see people dropping out of the trauma program, because I think that the level 3s and 4s play an important role within the system.
Well said, and we appreciate your advocacy because we need more voices like that. Thank you.
Yeah. Well, I'll be glad to say it to whoever needs to hear it.
Damien, I think you bring up a good point. I know my hospital has been going through an exercise as far as correlating level of activation and then ER documentation, and then being able to send out the actual like trauma charge. And I'm starting to speak language that I don't really understand because I'm a clinical provider. But and then on our last GTC meeting, Liz, y'all were bringing that up as far as like going with TCAA and working with them as far as like, how do we document in our notes in order to be able to bill? Because if the legislators are saying, look, GTC should be the last line of financial support, not the only means of financial support to being a trauma center, why can't insurance companies, cough up and actually pay for the care we're providing? And so I think that, again, I'm not sure how much money difference that will bring in, if it will. It's got to help, but I don't know if it'll solve the financial issue. And that's honestly why we wanted some questions on that survey about like financial support of hospitals. And maybe it's just because administrators, y'all are the ones that are responsible for thinking about the financial viability of the programs. And as a doctor, like, I don't necessarily always think about how are we going to fund our program. And that's why we have y'all. And so I hope that as we learn more about how to appropriately document, that we can capture more of the payment, like get paid for the work you're doing, So what are your thoughts on that, Damien, Liz?
Yeah, I think we've recognized that through the work that we did, that you all were wonderful participants in sharing your information about your claims data, but we found a lot of challenges with that. In fact, I just had another call with GHA about how to, get Georgia Medicaid on the same, basically aligned with NUBC and using the 68X code for trauma activation. So I see a little, Chelsea just put something in the chat about she did a TCA finance consult in February and it was really helpful. I know that one year we paid for all level 4s to have a membership with TCAA so that they could have their one-on-one consult with TCAA. But another thing we might be able to do is to just get TCAA on the phone with a bunch of level 4 leaders, because I don't know what reimbursement on the claims side looks like for level 4 reimbursement. Now, some of you that are not critical access hospitals, and like Damien, you have an ICU, and I don't know if you admit trauma patients to it or not, probably not, but for those of you who do, and for the level 3s, there's also the ICU accommodation code. So, a lot of our efforts in doing that were really what you spoke to, Alicia, is payer of last resort, right? We do need to make sure we're maximizing those efforts. So I think there is still a little room on that side to make sure that we're optimized on our billing and coding and claims.
Sorry, I was trying to look at the chat comments about what different people have used, like resources. Let's see, Rachel said we don't know what the reimbursement looks like either. Any communication with TCA will be helpful. Yeah, I mean, I think that, this meeting, we need to wrap it up, but obviously this is an area to look further into. So I think more to come on this. But I'm excited to see everybody in person in August. I appreciate y'all's time this morning. And again, especially I think everybody is, a lot of people are showing interest in the PI work group, that's awesome. I really appreciate y'all's willingness to volunteer even more of your time than you're already giving. But really, we need also some folks for the other work groups too, because otherwise we're just not going to be able to move the needle on those points. So, okay, well, y'all reach out to me if you have anything between now and August, and we'll get some emails going on these work groups. And don't forget to either scan the QR code or log your attendance in the chat. I appreciate y'all's time this morning. Thank you.
Thanks, Dr. Redisher.
Thank you, guys.